Okay, so I've titled this a unusual complication after transcatheter pulmonary valve replacement. I'd certainly not seen it before, haven't seen it since, but it is an evolving issue. I think what we're finding with transcatheter pulmonary valve replacement is that as we're finding the solution to one issue, we're uncovering another, and this may be something that's uncommon but worthy of discussion and certainly worthy of evaluation. So this guy, we'll do it this way. It was a 22-year-old patient who had valvular aortic stenosis and had a balloon in childhood, developed progressive AR and underwent a Rossen in 2007, had a 27mm RV to PA homograft put in. He had a progressive homograft dysfunction with a mean gradient of 37mm of mercury, and I suppose depending on whether you're in compassion or the melody cohort, the mean gradient suggested for intervention was somewhere between 30 and 35, but we felt, based on him and his symptoms, that it was reasonable to go ahead and consider transcatheter pulmonary valve replacement. So this was an initial angiogram. As you can see, he's got a heavily calcified homograft there in the frontal view, and somewhat probably less pronounced because it's a little bit asymmetric on the lateral view. So again, we've had a very standard approach, assessment of the coronary artery proximity. We did serial balloon inflation. I had some concern regarding potential for homograft disruption just because of the circumferential calcium. So at the time when I was working in the US, we didn't have the availability of a covered stent. So Ziad had taught me how to make our own covered stents by getting some ETPFE that's expandable up to 24mm and mounting it onto a bare metal stent, crimping it down on a balloon. And actually with this case, rather than pushing it up through the sheath, which there's some concern about rubbing the ETPFE off the stent, we front loaded it and put it up and implanted a pre-stent. And you can see after the first pre-stent here that we've opened up that there's no evidence of conduit disruption. We put a further pre-stent in because you still see there's a little bit of a waste on the frontal towards the patient's left-hand side, over towards the LPA there. But on the PA or on the lateral view, it looked reasonably homogeneous. And then we went in and put in a 26 sapien valve and got a reasonably nice result from it. You can see the valve, again, the slower balloon inflation, and then when you feel you're in a reasonable position, inflate and stick the valve to the target zone. So then the final angiograms from this case, you can see we've got valvular competence. I'm not sure. I think we probably had pullback gradient of around about 12 or 13mm of mercury. Then we do the down the barrel view to have a look at it. It's probably not fully circular, but we felt it was a reasonable result. And then you see the aorta. I suppose the aorta is the thing to be mindful of. I don't see any filling of the PA there at all. There is, I suppose, abutment of the stented complex up to the aortic root. The coronary certainly look okay. The guy went home the next day, everything seemed fine. So he came back to see me in clinic about 8 weeks later. He said he felt great. It was a peak gradient, Doppler gave about 21 across the valve, no pulmonary regurgitation. But when I listened to him, he had this continuous murmur, and no matter how hard I tried not to hear it, I still heard it, which was very annoying. So probably maybe the moral of the story is don't listen to the heart if you don't want to find anything out. But we had this little jet here that was coming just above the stent valve complex, just in here. And when we did a Doppler trace on it, was continuous flow. So we had continuous murmur. We had an echocardiogram that was suggesting there was flow into the PAs from the aorta, and the Doppler trace that suggested there was a continuous flow from the aorta into the PAs. So options. Anybody got any thoughts?
Already gave it away.
Yeah, well, I suppose I did. But in relation to imaging, we thought, well, look, I'm not sure what's going on. Why not let's get a CT? It buys you some time. So we did a CT PA here and got some nice views. And you can see just at the origin of where the LPA comes off here, you can see this little connection. And again, we see it on these sagittal views, this connection here that we could see in between the aorta and the pulmonary arteries just above the stent complex. So I went, wow, I've not seen this before. So of course I went to Professor Google and Professor PubMed and actually found that the group in Mayo had described a case in congenital heart disease just a year previously where they'd had an issue with acute heart failure after percutaneous pulmonary valve implantation, again secondary to an aortopulmonary fistula. In that case they had sent the patient to surgery. The patient had had successful surgery and had done reasonably well. And again, the group described their follow-up on the patient, because when they'd initially described it, they'd written it up and weren't really sure, and then they had a sort of a letter to the editor describing the surgical outcome and whatnot. This guy was really well. He was asymptomatic, although he did have a continuous murmur. We felt we were probably committed, or should be committed, to treating it rightly or wrongly, but we didn't really feel like sending him to the operating room. So we took him back to the lab, and we did an aortogram. Again, it's difficult to see filling of the PAs, but when we actually, you can see probably a little bit on the lateral here that there's a suggestion that maybe there's some filling of the PAs in this one. And then when we just did a still frame, we could see that there's this little leak here from the aorta back in towards, I suppose, the origin of the LPA, just the distal portion of the MPA. We did some transesophageal echocardiogram as well. Again, you can see here, this is the stent valve complex in the RVOT. And again, there was this jet here, continuous jet with a continuous Doppler trace suggesting flow from the aorta into the pulmonary artery. So we decided to go after it. Oops. I don't know whether this will play. Not sure if this one will actually play, but what we did was we created an AV loop, crossing it from the arterial side and pulling it out, exteriorizing from the venous side, and then coming up, and we balloon sized just to have a look at it because our imaging wasn't fantastic. It was very, very small, as you can see. And then we kind of came into the concept of what device we should use. Does anybody think we shouldn't have done this at this stage? Okay, we have one person. You don't think we should have done it? You'd like to close it. So device-wise, any thoughts on a device that you might consider using? Yeah, I mean, with the balloon sizing and everything, it was really just a couple of millimeters, probably 3 or 4 millimeters. So I suppose the AD02 was something that we considered, but I think what we were concerned about was the wasting and ensuring that nothing either impinged upon the aortic valve or on the pulmonary valve or on the stent complex itself. And rightly or wrongly, the lowest profile device that was delivered up to a 4 French sheath, we put in a 6 millimeter AVP4. And as you can see here from a deployment perspective, let's see if this... here's the device here. Sorry, these angios for some reason don't seem to be playing, but we put the device in. You can just see it here. And when we shot an angiogram, there was no residual flow. And this is the transthoracic echocardio, transesophageal echocardiogram at the end of the procedure. We didn't really see any flow into it. Again, here's the device just sitting here. Wasn't impinging upon the aortic valve. Again, here. And then we did some 3D TE as well, and you see it actually sitting here again with no impingement on either valves and no issues. So the final angiogram then, we don't see any flow. We can see it sitting just above the stent complex here and here posteriorly. Again, that jet that we'd previously seen was gone. So I've seen this guy now probably, or I had seen him until I left the States in July, with a year's follow-up, and he was looking fine and doing well, and we'd no further issues with it. And it was interesting, we wrote the case up just because I felt it was interesting, and then subsequently a group of people have got together, probably heralded by Doff McElhenney, and looked at iatrogenic aortopulmonary communications after transcatheter interventions on the right ventricular attack of pulmonary artery, and just, it's in press. Well, actually, maybe it's just been published in the last month or two in CCI. And, you know, this is an evolving issue. I suppose we've all known about the potential for aortopulmonary fistulas with balloon procedures in transposition patients or the like in years gone by. But I think as we're putting more rigid objects into the RVOT and butting them up against the aorta, there is the potential for aortic distortion and the potential for AP fistula. And just some of the images from this paper I'll finish with just to show you. This was a patient with double inlet, just these two images, the top double inlet left ventricle who had VA discordance and ended up having an arterial switch and then went down a single ventricular route, but had an LPA stent in here. And you can see a couple of days after they put in the LPA stent, the patient presented with symptoms, and you can see there's an AP fistula there, and they actually resolved it by putting a covered stent in. This is another patient here who had transposition and ended up with a conduit and had a stenosed conduit and therefore had a melody valve implanted and an LPA stent. And again, more so with the LPA stent than the conduit, you can see how the aortic distortion is somewhat more pronounced after the LPA stent has gone in. And just finally, this is a Ross patient, and these are three separate patients. Sorry, this first one here is a Ross patient. You again see in an MRI, you can see how the conduit really does abut up against the aorta in this circumstance. And this is another Ross patient who's had a conduit in, has had a melody valve put in, and again you can see how it actually butts up against the aorta. And again, I think the importance of exit angiography, maybe if it doesn't show you anything, what it'll at least do is act as a marker for the future should there be any issues with any problems with aortic-pulmonary fistulas. And again, this is a truncus arteriosus patient, again, who's had a homograft replaced in the aortic position as well due to truncal valve regurgitation, as well as the RVTPA conduit. And what you can see is that with a intervention on the conduit here is that there's cracking of the calcium on the aortic side, again suggesting that there's potential for imposition on the aorta with these heavily stenosed conduits or interventions on the right ventricular outflow tract. So I'll leave it at that. Thank you.